This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, a joint venture between the HMA and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You will find the evaluations by following the link in the chat at the end of this talk or at any time on our website and email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Bello has disclosed that she has no relationship with commercial supporters that would be a conflict of interest in this presentation. It's my great pleasure to introduce Dr. Erlaine Bello, our speaker for today. She got her bachelor's in biochemistry and religious studies major at Occidental College, her medical degree here at JABSOM, and she then completed a primary care internal medicine residency at the University of Hawaii, followed by an infectious disease fellowship at Harbor UCLA. She also has a Master's of Science degree in clinical research from JABSOM. She's an associate professor in the Department of Medicine, and her clinical practice of infectious disease is at the Queens Medical Center in POB1 and an ID clinic at Queen Emma Clinics. She is the hospital epidemiologist and chair of the Infection Prevention and Control Committee, member of the COVID Committee, and co-chair of COVID Therapeutic Subcommittee at Queens. She is also a PMAG member. Please join me in welcoming Dr. Erlaine Bello. She'll be talking about matching therapeutics to the spectrum of COVID care. Welcome, Dr. Bello.
Yeah, thank you. Thank you very much, Kamal. Happy Valentine's Day to everybody. So I'll go ahead and start here. So I'm going to talk today. Oh, let's see. I can't advance my. Okay, so I'm having some trouble advancing my slides here. Here we go. Okay, so I'm going to talk today about the stages of COVID infection and talk about the main categories of drug therapies that are available for the various stages of COVID infection, and then summarize the indications for pre-exposure therapy, which is really the latest advance in treating outpatients with mild to moderate disease. So I'm going to start with a case that happens to be a geriatrics case. And this is someone that I actually took care of in the past week. The patient is a 91-year-old Caucasian female with multiple chronic diseases, hypertension, diabetes, CKD, and she has moderate dementia. And she completed her primary vaccine series, but unfortunately was not boosted. And her dementia is such that she requires 24/7 care. And all of these caregivers have been vaccinated. It's uncertain what their booster status is, but they do unmask around the patient. So one of the caregivers was diagnosed with symptomatic COVID and notified the patient's daughter. But unfortunately, 2 days later, the patient herself developed a non-productive cough, poor appetite, and generalized weakness. So the patient's daughter took it upon herself to do a rapid home test. That was negative, but then took her to a testing site to do the PCR. However, before the PCR results came back, the patient developed desaturation down to the high 80s, which is definitely abnormal for her. And she was taken to the ER at Hospital X. So in the ER there, she had a rapid COVID test that was positive, and she was admitted because of her hypoxia. But she was also found to be in acute heart failure, but with a preserved ejection fraction and AKI. She ceftriaxone, doxycycline, and decadron. And then she seemed to do well and was discharged 6 days later with a room air saturation of 94%. However, once she got home, she did poorly, and she had poor appetite, poor intake. She was very restless, and her pulse oximeter again dropped down to the 80s. So within 4 days of her discharge, she went back to the ER at another hospital. And she was hypoxic once again, had AKI once again, dehydration, a urinary tract infection, elevated procalcitonin, but a normal white count and lactate. And her portable chest x-ray was read as no acute disease. She was given IV fluids, vancomycin, pip-tazobactam, and about 2 days into her hospital stay, because of persistent hypoxia, a CT of her chest was performed, which showed bilateral reticular and ground glass opacities. Throughout the entire stay at Hospital B, she had no cough, but she was hypoxic, requiring 4 liters to maintain her oxygen saturation. And at that point, an ID consult was obtained. She was given IV remdesivir and screened for tuberculosis and fungal infection. By hospital day 10, she was on room air with O2 sats between 95 to 98%. So this case illustrates several things, and we'll go back to this case at the end. But just to review where we are in the state, so you can see here we are, we're on the downslope of this rapid peak with the Omicron surge. And you can see the striking difference between the total number of cases with Omicron and the previous surge, the Delta surge earlier, well, at the end of last year, or actually mid of last year. Okay, and this is the hospitalizations. So you can see that even though the Delta surge was associated with a lower number of total cases, the number of hospitalizations associated with Delta was extremely high. For Omicron, although the peak number of actual cases was much higher than the Delta, you can see that the number of hospitalizations is almost the equivalent of the Delta, even though that we know for the majority of people with Omicron, this is a much milder disease. And the trend in ventilator use also shows us that Omicron is a relatively less severe disease than Delta, but there are still people ending up in the ICU on ventilators. And these are primarily the unvaccinated, unboosted, and people who were immunosuppressed or at greater risk of serious infection. Okay, so this is a complicated slide, but this is probably the most important slide in this whole talk. Okay, and it shows the stages of COVID infection and how mild COVID differs from severe COVID. So starting at the top, so mild COVID, so you can see the symptom onset follows virus shedding. So this is where, again, people can transmit the disease, yet not even know they have it. Okay, and people with mild COVID may progress to an early inflammatory phase, but they're all pretty much symptom-free by 2 weeks. Okay, and their virus rapidly wanes. But this is in contrast to people with severe COVID infection. So people with severe COVID infection have a longer period of viral shedding and infectiousness. They have a longer, more sustained period of viral detection by our PCR tests. But they distinctly have a stage of viral infection then subsequent stages that are really the result of the inflammatory response by the host. So in stage 1, this is typically influenza-like illness. For Omicron, it was actually even more of an upper respiratory type illness. Okay, then the people with severe COVID go on to develop progressive respiratory symptoms and hypoxia. And then a smaller group, but these are the people who have the greatest morbidity and mortality, go on to stage 3. And this is where we see ARDS, multi-organ failure, and severe coagulation disorders. But the take-home message is really the therapy should be matched to the stage of disease. And we're fortunate that we are now developing therapies for mild disease or early disease to prevent subsequent development of stage 2 and stage 3 disease. So who is at risk of severe COVID infection? So I already mentioned the unvaccinated, but definitely everyone in the geriatric age group is at risk. So we know that people over 65 years of age have an increased risk of hospitalization as well as death. And definitely the 85-year-olds and above have the highest risk. Persons with underlying lung disease, heart disease, malignancy, especially hematologic malignancies, and the associated treatments are at greater risk. So pregnancy, as well as recent postpartum, is another risk. And then a whole slew of immunocompromising diseases and treatments. Diabetes itself is a risk. And mental health conditions also seem to be at risk of more severe COVID infection. Dementia, Alzheimer's, cognitive impairment, and developmental neurologic diseases. And then chronic liver disease, kidney disease, smoking, although this may be related to lung disease, and then vaping for the same reason, for the effect that it has on the lungs. So COVID infection in older adults, we know that 75% of deaths in the United States occur in people 65 and older. And this age group accounts for over 42% of admissions for COVID. And again, this makes sense because older people, as all of you know, have more likelihood of chronic diseases that put them at increased risk. Older people have aging immune systems and probably aging lung tissue also. And it's becoming apparent that older people also can have a more intense inflammatory response, resulting in the multi-organ failure in people with severe COVID. And just additional elaboration on the lung diseases that increase the risk of severe COVID, COPD, pulmonary fibrosis, pulmonary hypertension, interstitial lung disease, bronchiectasis, and then asthma, mild asthma may not, but definitely people who have uncontrolled asthma are at greater risk of severe COVID. And then I just want to go through some standard definitions of severity of illness. So these are the standard definitions that the various therapeutic studies use. So mild to moderate disease are people who are not in the hospital. They do have symptoms though, as opposed to asymptomatic COVID. Okay, and they do not require oxygen. But if they are on oxygen for other chronic illnesses, they don't require an increase in their baseline oxygen rate due to COVID. Severe infection has been defined as people's O2 sat is below 94% on room air, including patients on supplemental oxygen. And then critical COVID are those people on mechanical ventilation, septic shock, or on ECMO. So keep these in mind as we go through the various therapies. Okay, then just to review the basic coronavirus structure. So this is an RNA virus. Probably besides the RNA genome, the most important structure is this spike protein. And this spike protein is the target of most of the monoclonal antibody therapies. Okay, and just a review about monoclonal antibodies. So this is what happens very simply when the virus binds to the host cell, if there are no antibodies involved. Let me just turn that off. Okay, but if you have antibodies, the monoclonal antibodies will actually block the virus by binding to this spike protein so that the virus is not able to bind to the host cell. Okay, and the monoclonal antibodies that are currently in use are made in the lab. Okay, and they're generally intravenous. There are some that are subcutaneous. Okay, and these are the typical side effects of all monoclonal antibodies. So acute hypersensitivity type reactions, rash, even anaphylaxis, flu-like symptoms, myalgias, fevers, including during the infusion, non-specific gastrointestinal symptoms, and often low blood pressure, even in those people who are not having frank anaphylaxis. Okay, then just to review the spectrum of therapeutic opportunities that we now have for COVID. So starting with prevention, so vaccination, and that's a whole talk in itself, so I'm not going to cover vaccines. But we do have pre-exposure prophylaxis, which is very similar to the PrEP that we use for HIV infection. We have very limited post-exposure prophylaxis now that we're into the Omicron era. And then there's a spectrum of therapies for acute COVID infection as well. And I'm going to talk about monoclonals, antivirals, corticosteroids, and some of these inhibitors, but I'm not going to talk at all about anticoagulation. But basically, anybody who's severe enough to be in the hospital should be on some form of anticoagulation. Okay, so here are the treatment options for hospitalized patients. So steroids, remdesivir, which is an antiviral, tocilizumab, baricitinib, and then we also should not forget about all the supportive care that goes into the treatment of hospitalized patients. So nutrition, glucose management, and always monitoring for secondary infections that might have been present either at the time of admission or acquired in the hospital. Okay, so starting with steroids. So for patients with severe and critical COVID, this is definitely one of the mainstays of treatment. Okay, but it should not be used in patients with who are ambulatory, who have normal oxygenation, or those with chronic hypoxia who are not worse than their baseline. Okay, and the Treatment regimen is 6 milligrams IV decadron, or the oral equivalent, for up to 10 days, or until hospital discharge if their stay is less than 10 days. And you can use equivalent alternate glucocorticoids. For those who have acute or chronic co-infection, obviously they should be used with caution. And if patients are requiring steroids for other non-COVID conditions, they can be continued. Then tocilizumab. So tocilizumab is a monoclonal antibody. It has FDA EUA status. So just to review, EUA means emergency use authorization. So this means that these drugs that have this status have not gone through the usual rigor required by FDA for FDA full approval. So these drugs have not necessarily gone through the usual standard phase 1, phase 2, phase 3 studies. But this is unique in that it's not monoclonal antibody against the spike protein, but it's monoclonal antibody against IL-6, which is one of the cytokines that is thought to be part of the severe inflammatory response. So accordingly, should be given to people with severe or critical COVID who have evidence of systemic inflammation. So elevated CRP, sed rate, ferritin, and it should be used in combination with steroids. So it's a single infusion of 8 milligrams per kilogram. And there have been a number of randomized clinical trials. However, the results of those are mixed, okay? And there's definitely an increased infection risk with this drug. So patients should be monitored closely for signs of secondary infection, especially because they are on steroids as well. Baricitinib is also kind of a unique drug. It also has EUA status, and it's a JAK inhibitor. It should be used only for hospitalized patients with COVID pneumonia. It's a daily 14-day course. And the Infectious Disease Society of America recommends it only if the patients cannot tolerate steroids for whatever reason. It has to be dose adjusted for renal failure. And the Act 2 study looked at baricitinib plus remdesivir versus placebo. So for some things, it looked like there was an improvement. So the mortality at day 29 was 4.7 versus 7.1 for the remdesivir plus placebo group. Okay, but there was not much difference in the median time to recovery or the number of patients who progressed to non-invasive ventilation or higher levels of oxygen or mechanical ventilation. And definitely these patients need to be monitored for superinfection, thrombosis, neutropenia, lymphocytopenia, and abnormal liver function. So not an impressive drug. Okay, then moving on to remdesivir, which is our mainstay antiviral. So this is the only FDA-approved drug for symptomatic COVID. And the way remdesivir works, remdesivir is actually the prodrug to this active metabolite that will bind to the RNA polymerase and inhibit the replication of the SARS virus RNA. Okay, and remdesivir can actually be used both for severe illness and patients with mild to moderate illness. So in the hospital setting, it's a 4-day course, okay? It's specifically not recommended in patients on mechanical ventilation or ECMO. There's not been much data, but if you think back to the first diagram that I showed you, by the time people get on mechanical ventilation or ECMO or who have multi-organ failure, they're really out of the viral phase of the illness, and their disease is really determined by the host inflammatory response. It should not be given to people with a GFR under 30, elevated liver function tests that are more than 5 times the upper limit of normal, and liver function and the prothrombin time need to be monitored. It's still EUA status as opposed to FDA approved for pediatric patients under the age of 12 or between 3.5 and 40 kilograms. And more recently, remdesivir has also been added to the armamentarium of folks with mild to moderate illness within 7 days of symptom onset. So for outpatient use. Okay, so it's a little more difficult to administer this drug as an outpatient over 3 consecutive days, but this did result in people with mild to moderate illness in an 87% relative risk reduction in hospitalization and death. So you can see this regimen is also a little different from the severe illness regimen. So it's 3 days as opposed to 4 days. You can also use it for patients who are admitted to the hospital for some other diagnosis than COVID, yet also have mild to moderate COVID. Okay, then other options for mild to moderate COVID. So all of these are given in the outpatient setting. And all of them, again, have this FDA emergency use authorization status. So these are indicated for those at high risk of disease progression. So the 2 main categories are the antivirals. So remdesivir, we just talked about, but there's also Paxlovid and molnupiravir. And then there's a whole bunch of monoclonal antibodies now. So the problem with these monoclonal antibodies being administered as an outpatient excuse me, is that all of these require a 1-hour post-dose monitoring period. So Lilly has kind of been in front of the game with these monoclonal antibodies. So they actually developed the first one. And then Regeneron came out with REGEN-COV. GlaxoSmithKline is responsible for sotrivimab. And actually, over the weekend, actually last week, the most recent monoclonal antibody was released by Lilly. And they signed a contract with the US government for 600,000 doses to the tune of $720 million. So you can see for these drug companies, it can be very lucrative. Okay, and for all of these, there are no comparative studies. So we can't say that any one of these is better than the other, but their efficacy is determined by the relative risk reduction of hospitalization or death compared to placebo in ambulatory non-hospitalized patients who have lab-confirmed COVID. So you can see Paxlovid, sotrovimab, remdesivir, they're all very similar in reducing the relative risk of hospitalization or death. This last one, molnupiravir, though, is somewhat of an outlier. And there's no data on combinations of antivirals or combinations of monoclonal antibodies or combinations of antivirals plus monoclonal antibodies. Okay, then I'm just gonna digress a little bit on the monoclonal antibody story because I think it's very interesting. So these are monoclonal antibodies against the spike protein for COVID. But this constant development of monoclonal antibodies is really due to constant evolution of the variants. So going back to November of 2020, bamlanivimab, or what Queens affectionately calls Bam Bam, received EUA status. This was followed very shortly by this combination, which is Regencov. And then in February of last year, bamlanivimab was used in combination with a second monoclonal. Okay, and then in May of last year, sotrovimab received EUA status. But the next month, the FDA put a pause on bamlanivimab and etesevimab because of a rising Delta variant prevalence. So this was the beginning of the surge last summer. And then in January of this year, the FDA put a pause on Regencov because of widespread Omicron. Okay, and we just, again, had this recent new entrance into the monoclonal antibody field, which does have activity against Omicron. Okay, and this is some of the neutralization data. And you can see the different variants here. So Bam Bam, again, was very good against the alpha variant, okay, but had way less activity against the beta variant and the Delta variant. And then you can see this is a combination that made up Regencov. So again, for the Delta variant, it was effective, but we'll see what happened with Omicron. Okay, so again, this is casirivimab, imdevimab, and this is Regencov. So again, very effective against the ancestral strain, effective against the Delta variant, but really not very effective against the Omicron variant. Okay, so sotrovimab is the current or the first monoclonal antibody with good activity against the Omicron variant. And like all of these FDA EUA drugs, these are given out to the states by the US government. So these are free to the patient, free to the health systems, okay, but they are on allocation. And when sotrovimab first came out, the first allocation to the Queens Health System was 12 doses. So at that point, we had to develop some kind of system to triage the patients for administration. So this one has to be given within 10 days of symptom onset. And again, it's for those with mild to moderate COVID, the way we've just defined it before. They can't be on oxygen, or if they're on chronic oxygen, it can't be due to COVID. And they have to be at high risk of progression to severe disease. And we'll look at the triage system that we had to develop. It's a single dose. And again, patients need to be monitored for an hour after infusion, and no unique monoclonal antibody side effects, just the typical that I already covered. Okay, so this is a triage system that we developed internally at Queen's, and is not really developed based on any, I guess, published article, but there are data, again, of these being people who are more likely to progress to severe disease. But how we assign the points, again, is somewhat arbitrary. So we gave 2 points for age over 65 or older, high BMI, pregnancy with the rationale that we're protecting 2 people. And because we know immunosuppressive disease, immunosuppressive medication, chronic lung disease are all high risk. And we actually subtracted points for people who received the vaccine and the booster, again, with the thought that they would be relatively more protected. And so a score of 6 early on is what we required to qualify when we had a limited supply. And we also are using the same system for Paxlovid right now. But what has changed is that we do have, at this point, a way better supply. Okay, then Paxlovid is also an antiviral. So it's a protease inhibitor. So as you know, protease inhibitors came into use during the HIV era. And this is a ritonavir boosted drug. Okay, and again, the efficacy very similar to sotrovimab, same kind of indications for mild to moderate disease. What is unique about Paxlovid is that it's oral, so much better for ease of administration as an outpatient. It's a 5-day course. Okay, and severe renal and liver impairment are contraindications. Okay, and there's the theoretical concern that there may be an increased risk of HIV developing resistance if people are going to be on protease inhibitors. But the difficulty with Paxlovid is that it interacts with a number of commonly used drugs. So it's contraindicated with drugs that are very dependent on the CYP3A cytochrome system for clearance. So you can see some of our very common day-to-day drugs, the statins, colchicine, piroxicam that people are commonly on are contraindicated. And then another additional list of relatively common drugs and a herbal product, okay, that might result in reduced Paxlovid concentrations, again, associated with the CYP3A cytochrome inducers. Then molnupiravir is another antiviral, and it's the one with the probably lowest efficacy. This one has to be given within 5 days of symptom onset. It's a 5-day course of capsules. There's no dosage adjustment for renal or hepatic failure. Some of the side effects, diarrhea, nausea, and dizziness, but it's contraindicated in pregnancy due to some evidence of teratogenicity in animal studies. And so it's really recommended only if there are no other options available based on the relatively low efficacy and, again, these concerns about teratogenicity based on animal studies. Okay, so we do have a number of options available. And so the choice of drug really comes down to patient factors, product availability, as the EUA status is triggered by distribution by the federal government that then doles it out to the states to allocate the drugs. And then it's also about institutional capacity and infrastructure, especially for the monoclonal antibodies. So for people who actually have COVID and are getting these treatments, you have to have a location that's isolation capable. And then you have to have some place for them to go for an hour of monitoring. And then you need people who are experienced with isolation that is required for COVID infection. Okay, and then there are additional requirements in administering these drugs or any drug that has this EUA status. They have to be given in settings where the administering healthcare provider has immediate access to medications to treat infusion or hypersensitivity reactions and the ability to activate EMS. And so we tried early on to get, these set up in our existing clinics, but this became too much of a burden for most of these clinics. And then any medication errors and all serious adverse events related to EUA drugs require extensive reporting to the FDA. And then another thing about all of these EUA drugs for mild to moderate illness, we can't forget that these drugs are not necessarily curative of the infection. So we're typically seeing people early on in the course of mild to moderate illness, but they need to continue to self-isolate and use the standard infection control measures, even if they receive these drugs. So they're still potentially infectious. Okay, then I'm going to move on to the next category, and this is therapy for post-exposure prophylaxis. So this was very short-lived. So the only drug that was available for patients who had been exposed but were not yet infected really was Regencov. Okay, but now that we're into Omicron dominance, this drug is really no longer effective for post-exposure prophylaxis. Okay, then I'd like to finish by talking about Evusheld. So this is a drug for pre-exposure prophylaxis. This is, again, EUA status. It's a combination of monoclonal antibodies, and it's, again, directed at the spike protein. And it also is on allocation from the state to the various healthcare systems. So this is for pre-exposure prophylaxis. So this is not for infection, and this is not for people who have been exposed. And it's directed towards those patients who have medical conditions or treatments that may result in moderate to severe immunocompromise, or who are expected to have an inadequate immune response to vaccination. or for people who cannot tolerate the vaccine because of severe allergic reactions. But it's not intended to be a substitute for vaccination. So all of these patients should at least have an attempt at vaccination unless they had a previous severe allergy. And in order to get this drug, you have to have a negative COVID PCR within 72 hours of the treatment. The most common side effects reported so far are headache, fatigue, and cough. Okay, so this is a busy slide. This is from Nebraska Medicine, but this is the part of the guidance for all of the Hawaii health systems who are using it to prioritize the administration of Evusheld. So people have been risk stratified from 1 to 4. And at Queens, we're currently giving it to people primarily in category 1, 2, and 3. So you can see the major categories of immunocompromise, hematologic malignancies, solid tumors, and solid organ transplants. So virtually anybody who's a solid organ transplant is either in risk category 1 or 2. And so you can see that, again, as you go down these risk categories, there's lesser degree of immunocompromise. So the ideal was to treat this category first, then risk category 2 within the first 3 months, then risk category 3 in the first 6 months. But remember, we're on allocation, and it's also been somewhat of a challenge to get this drug out, I guess, to the masses and make practitioners aware. So as of the 8th, we had 3 patients treated. We had 50 referrals. But some other rate limiting problems is for people who had not yet completed the vaccine series, people who actually got on the list but were exposed and had to wait out their quarantine, and then patients who were on the list who actually developed COVID. And then we went on a campaign to communicate about this drug to our providers. And the subspecialists, besides ID, who typically see these immunocompromised patients, were our target communication group. Okay, and then I just want to show this slide to show how far we've come. So this was a slide that I used for various talks in 2020 into the beginning of 2021. But many of the drugs that we had in our armament, or what we thought was our armamentarium at that time, are considered really no longer effective. So you can see remdesivir is still on here, steroids are still on here, IL-6 inhibitors, JAK inhibitors. But the Infectious Disease Society, in their practice guidelines in the most recent update, clearly states that these are ineffective therapies. Although I would guess that many of you have taken care of patients who might still believe in these. So chloroquine, hydroxychloroquine, we actually had a small study on this. Lopinavir, ritonavir, which is the HIV drug Kaletra. And we were actively giving convalescent plasma in hospitalized patients. Then there are a number of drugs that are still widely circulating in the media as potential effective treatments for COVID. But the IDSA recommends that these drugs should not also be used outside of a clinical trial. So ivermectin, fluvoxamine, famotidine, and then convalescent plasma in mild to moderate illness. So there are studies going on, clinical trials going on for all of these drugs. Okay, then I'd like to end by sharing some of our outcomes data, our experience with the mild to moderate illness treatments. And just want to acknowledge Mia Taylor, who provided these slides. Mia and her QCIPN group have worked so hard delivering clinical care, as well as making these COVID outpatient therapeutics happen. The TCMP team is critical in doing the last screen before the patients get the drug, making sure, again, for Evusheld that they're not actually infected with COVID. And then our whole COAGS group, which is a multidisciplinary group of physicians, pharmacists, Mia and her group. So this is our experience with REGEN-COV. So we looked at a 28-day post-infusion status. So again, this is not a controlled study by any means, but it was a way for us to see, exactly what happened to our patients. So we gave a total of 747 doses during this period from July to December. There were 2 deaths that occurred despite getting REGEN-COV. 23 patients still required admission, and 19 of these were actually related to COVID. And we still had 43 subsequent ED visits, 34 of which were associated with COVID. And we had to submit 6 reports for possible infusion-related events. And this is our sotrovimab data. So we've given over 100 doses since the end of 2021. 4 required admission related to COVID. And there were 5 ED visits related to COVID in the 28-day post-infusion review period. And then we actually, knock on wood, have not had severe reactions with sotrovimab. Okay, and Paxlovid, we've given far fewer. There was 1 admission related to COVID, 1 ED visit related to COVID. And we think that this is related to the drug interaction potential that screens people out. But we're going to have to look at that more carefully. Okay, so I just want to conclude with these takeaways. So the majority of our therapeutic options are EUA status. So again, have not gone through the usual FDA scrutiny. The options for inpatient management for the severely to critically ill really have not changed much in the past year. But we have had rapid expansion of outpatient drugs for the mildly to moderately ill that can be given in the ambulatory setting. The new COVID variants, spike protein mutations, have rapidly rendered the early monoclonal antibody therapies ineffective, but they are constantly evolving and newer ones have become available. And then Evusheld PrEP really represents the first drug that is available for pre-exposure of the immunocompromised and those who are either not able to mount an adequate vaccine response or cannot tolerate vaccine. So I think this is my last slide. But going back briefly to the 91-year-old, so she, again, is someone who's at high risk based on her age and comorbidities. The exposure to the caregiver is significant. And I think the lay public still believes that if you got your vaccination, you can't get COVID, and that it's okay to unmask, but it's not. There's also the use of the rapid test. So we know that there are a number of limitations of the rapid test, although they may be useful if they're positive in someone who has typical COVID symptoms or an exposure. The PCR is still the better test. And then this patient developed hypoxia, so she met the criteria for severe disease. Patients with severe disease should definitely get steroids, but consideration should also be given to IV remdesivir. And fortunately, she has a reasonable outcome to date. She's not yet out of the hospital. She's very deconditioned. And she definitely will be a candidate for the booster once she gets out of the hospital here. So I'm going to stop there and take any questions.
Thank you, Dr. Bello. That was incredibly informative. For our audience, if you have any questions, could you please type them in the chat box? Dr. Bello, I have heard this question at other venues, but I know you don't have a magic mirror, but do you have any thoughts about how much longer this pandemic might go? The evolution of these mutations and, different surges that we've had.
Kamal, you asked such easy questions.
I know.
So I don't have a magic mirror or magic wand or anything like that. But I think what we're seeing from the standpoint of viral evolution is that this virus, is, in order for viruses to survive, they have to mutate so that they can perpetuate themselves in us. So if they cause too severe disease, they'll kill everybody off and they can't reproduce and spread. So I think we saw that with SARS, we saw that with MERS. Okay, so I think there's a hint that may be happening. Okay, but remember, we also just had the Delta less than a year ago. So that one is, I guess, the greatest fear. It becomes both more transmissible and more severe. But I think in the path towards longer term viral evolution, it makes sense that it would evolve to a less serious disease. But, time will tell.
That's right. That's right. Yeah. There's another question about how long does Evusheld work? Is it a month? Is it longer?
Yeah, it's 6 months. Okay, but right now I don't think they're releasing it for second time use yet. So if you saw the Nebraska tier system, the original intent was to get to the highest risk first within a month, the next tier within 3 months. But now that we see operationalizing how this played itself out, that just didn't happen. So we'll see. But they have not yet released a second dose of Evusheld. We're still working on getting people in for the first dose, but 6 months is the magic number.
Can you comment on the January 22 Lancet Global Health fluvoxamine study conducted in Brazil? Do you think the findings were valid?
Yeah, so I think it's going to take more than just a single study to convince people that this is a viable drug. So again, it's one of those that let's see more studies. But again, people are using it outside of FDA approval. As we have used many other drugs in everyday practice.
That's right. Dr. Bello, what do you think about the recent announcement last week from our Department of Health that Japanese patients had higher mortality in COVID? For the last 2 years, they've been telling us that actually Japanese had lower rates of hospitalization and of mortality, and those were highest in Pacific Islanders. And then now there's this new study from the Department of Health that says Japanese have really high risk of mortality in the hospital. Any thoughts on that?
Yeah, so I would have to actually see their data. So that's not been our experience at Queen's. I can say that. So I really like to know how. I don't know enough about how they got their data.
Right. Okay, thank you. Are there any other questions for Dr. Bello? If not, Erlaine, thank you so much. That was a wonderful presentation. We know you've been incredibly busy these last 2 years. Thank you not just for this presentation, but for all you're doing for our community, to help get this pandemic under control. We really appreciate all you do.
Yeah, thank you so much for saying that, Kamal. And again, happy Valentine's Day.
Happy Valentine's to everyone. So all of you, don't forget to do your CMEs, do the evaluations to get your CME credits. And I think there's a link in the chat box, and hope to see you all again next month. Thanks, everyone. Bye.